today to the CT and cardiac MRI lecture series at Montefiore. If you miss it today, you can see us later in YouTube in our channel. Please put your questions under QA, and then we'll answer the questions at the end. It's a great pleasure to have today Dr. Achenbach. He is the current president of the European Society of Cardiology. He's the chairman of the Department of Cardiology and professor of medicine at the University of Erlangen in Germany. He was the founding president of the Society of Cardiovascular Computed Tomography, and he was the editor-in-chief of the Journal of Cardiovascular Computed Tomography. He has received several awards, including the Simon Dack Award from the American College of Cardiology in 2009, and the gold medal of the Society of Cardiovascular Computed Tomography in 2015. Also, he has been selected by onmini.com, a very famous site, as the most influential radiology researcher in 2017. It's a great pleasure to have you here today talking about CT for cardiac interventions. Thanks a lot.
Thank you. It's a pleasure to be here. And the topic, of course, is very close to my heart because I'm fortunate enough to be an imager on one hand and also do interventional cardiology on the other. In Germany, we can have this setup. And I think it's almost a match made in heaven, CT and cardiac intervention, at least to some extent. When you think about cardiac CT these days, mainly it's this what we're thinking of. We can visualize the coronary arteries. We can detect coronary artery stenosis. And because of the data that has become available, both accuracy data and outcome data, now the European Society of Cardiology recognizes coronary CT angiography as a class 1 recommendation in patients with suspected coronary artery disease, unless they have very high or very low pretest likelihood. The ESC guidelines say that you can choose either CTA or ischemia testing to work up patients with suspected coronary artery disease. So this, of course, really has made a difference for cardiac CT, and we've been working for so long to get cardiac CT recognized, coronary CTA as a diagnostic tool. And you can see the accuracies that have been reported. Here's a meta-analysis, which shows that the sensitivity to identify coronary artery stenosis is 96% in comparison to the invasive angiogram. So that's comparing anatomy to anatomy. The specificity is somewhat lower, as we all know, tendency to overestimate stenosis in CT. Within this meta-analysis of more than 64 slice CT systems, 82% specificity, again, in comparison to invasive coronary angiography, not in comparison to FFR or ischemia testing. We also know there are challenges. One challenge clearly stents, for example, since we're talking about interventions. In some cases, when image quality is beautiful, we have very impressive visualization of stents and in-stent stenosis. But when image quality is even just slightly impaired, when the stents are a little bit smaller, or when a little bit of artifact, like a bit of motion artifact, a bit of noise is in the image, then stents become excessively difficult to analyze. In general, there is an influence of image quality with what we can do with cardiac CT. Everybody who does cardiac CT, everybody who reads cardiac CT knows that image quality is not always the same. There are the brilliant cases, such as this one, where there's absolutely no impairment of image quality and everything is seen in a great extent of detail. There are the cases who are okay to read, but you don't always feel very comfortable. Here, for example, a case where a bit of motion here and a bit of motion here and a bit of motion here impairs the image quality, some calcification here, and you don't feel quite as comfortable reading these cases. And then the cases where image quality, and unfortunately they do occur, is clearly impaired to an extent that analysis for the detection of stenosis, for example, becomes impossible. As you can see in this case, with lots of calcium and some motion artifact, it could be stenotic, it could not be stenotic, we just can't say. So image quality plays a big role in coronary CTA. And for most of what I'm going to say today, when we think about using CT for interventions, of course, we tend to look at those cases which have very, very good image quality and take this as a prerequisite. High image quality, here's another example, shows you the anatomy of the coronary arteries very impressively. 3D reconstructed, of course, always looks beautiful, but all of you are involved in imaging and you know that the 2D images, because they have no thresholding like the 3D reconstructions do, the 2D images is where the information resides, where you can see the calcified plaque here, the high-grade stenosis here, you can sort of feel the non-calcified plaque surrounding the stenosis, and you can see the anatomy in great detail. Not a lot of plaque, this patient, but a high-grade stenosis. This is the comparison, this is the respective invasive angiogram, and you can see that a very good CT and a relatively poor angiogram, image quality-wise, sort of look alike. So there's not an order of magnitude of quality difference in invasive angiography and CT, but still there is a difference. This next case that I'm showing you is probably the best image quality you can imagine in cardiac CT, and also relatively good image quality in invasive angiography. And here you can see, if you start looking at the details, that actually invasive angiography, the basis for our coronary interventions, let me go back so we can see this again. Invasive angiography, well, this doesn't play. Let me just try that we can see this again. Invasive angiography still has an edge over the CT angiogram. Actually, here we go. So you can compare the image quality really of the invasive angiogram and the high amount of branches and sub-branches that you can see. While image quality is impressive in CT, you can see that the invasive angiogram really has higher resolution, both temporal and spatial resolution. Now, CT, on the other hand, has an advantage. CT can visualize plaque, which the invasive angiogram cannot. So we have plaque here, for example, non-calcified plaque sitting in the proximal LD, some calcified plaques here. And the advantage of CT is, of course, that you can look at this from different orientations. So you can see the calcified plaque here, seen in the longitudinal view, does not cause any stenosis. What you see here is the vein accompanying the artery. This is not a non-calcified plaque. This is the vein which sort of meanders around the artery. So there's just a bit of calcified plaque here. There is a mixture of calcified and some non-calcified plaque a little bit further proximal. And then, of course, here proximally, where you can see the completely non-calcified plaque in cross section, you can see that there is no calcification and quite a bit of outward remodeling. So CT can visualize plaque. So this is CT visualizing a stenosis here in ostial LAD, and you can see the completely non-calcified plaque that causes the stenosis. And this is the invasive angiogram, not of this case, but of another case to compare. The image quality invasive angiography is higher. You have more spatial resolution, more temporal resolution. Invasive angiography is real-time. We can use it for interventions. Invasive angiography is absolutely robust. There's basically no patient, no matter what the heart rate, what the body weight is, where you cannot perform invasive angiography. And of course, it's also the basis for our interventions when we fix these vessels. So CT on one hand, slightly lower image quality, but the ability to visualize plaque and three-dimensional data set. Invasive angiography, very high resolution, very fast. The exposure time for a single frame in invasive angiography is 8 milliseconds. Completely real time when you do interventions and extremely robust. And the question is now, if you think about intervention, is there a complementary role of CT imaging for invasive angiography in coronary interventions? Well, the summary, I would say, has it been explored? Yes, quite a bit. Is it a game changer for coronary interventions? Rather not. And I'll try to explain this. There are many things that CT can do that invasive angiography cannot. For example, and this is a long time ago, CT is a three-dimensional data set. You can slice the data in any orientation you want. You can measure angles, you can measure spatial relationships, and you can measure them much better in CT than in invasive angiography. Here's the measurement of angles, which correlate very closely in the CT scan and very poorly in the invasive angiogram, because the projectional nature of invasive angiography doesn't really allow to visualize angles very well. There's also some data that the type of plaque might have a predictive value regarding ischemic side effects, I would say, of angioplasty or PCI. There's data from Japan, for example, showing that if you have a lot of very bulky plaque before you do elective PCI in stable patients, you have a higher number of patients who develop peri-procedural troponin. But if you look at the data in detail, you can see most of patients are doing perfectly well, and there were just 2 or 3 patients who developed troponin and also happened to have large volume plaques. Maybe some of this was even thrombus. So yes, they can construct the relationship between plaque type and peri-procedural troponin, but it's not really very impressive. Similarly, there has been, the attempt to try and predict slow flow in patients who undergo elective angiography, and you can see that the features of plaque vulnerability, like positive remodeling, low attenuation plaque, and also the so-called napkin ring sign, were more frequent in those patients who had slow flow. In this cohort, 43 patients experienced slow flow, even though it was not acute coronary lesions. So small data set, interesting, but it's not really something that would change clinical practice. Other things have been done. Virtual and augmented reality enhanced interventions have been done on the basis of cardiac CT 3D scans. Is this done in clinical practice or in any reasonable scale? No, it is not. And there are some reports even of completely contrast-free interventions only based on fluoroscopy and the preceding CT angiogram. But again, this is probably just a report to show that the technique is possible, nothing that carries on into clinical practice. So have these things been explored? The connection of CT and routine coronary interventions, yes, they have been explored. Are they game changers? To be honest, rather not. And because invasive angiography is so robust and so practical and so real-time and so high resolution, CT will not, for the foreseeable future, have a relevant role in helping us with these interventions in routine cases. One area which is not quite as routine, and one area in which, for particular reasons, CT has been looked at rather intensively, is the recanalization of chronic total occlusions. Chronic total occlusions which are older than 3 months, or presumably older than 3 months, are a challenge interventionally. The success rate of reopening these, and the procedures can be very long, the success rate is in the range roughly of about 80–85%. The interventions can be very complex, to some degree also associated with complications. You can perforate the vessel into the pericardial space and so on. So the CTOs are a bit of an adventure in some cath labs, and in others, even though routinely done, always much more elaborate procedure than a conventional CT PCI. So there was interest to see whether CT might be able to be of some support, particularly in the context of CTO recanalization. Here you can see such a case. This is an occluded right coronary artery. You can only see the very proximal stump when injecting into the right coronary artery. Right here, now the contrast is coming and it's occluded here. The distal right coronary artery you can see when injecting into the left coronary artery. Already shows you that these are elaborate procedures, and you can estimate the occluded segment between the proximal and the distal visualization of contrast enhanced lumen. This must be the occlusion, but much more you can't really say. In CT, obviously, same case on the right-hand side, you can see the occluded artery, you can see the stump here, you can see the occluded segment, which is positively remodeled almost, one would say. It's outwardly expanded. It's completely non-calcified. You can measure the length. You see that there's no significant bend in here. But then again, the experienced interventionist will also be able to estimate from this angiogram that there's no big bend in the occluded segment. Anyways, this is the sort of information, the sort of visualization that can be obtained by CT as compared to invasive angiography. In this case was a bit elaborate, required more than one wire to be passed down the artery, but eventually, as anybody would expect, this was a reasonably easy and straightforward CTO recanalization and was successful. Of course, there are also cases which are not successful. I said the success rate in average is in the 85% range. Here's a case that was not successful, and you can see the difference. In CT, you can see the massive calcification of the entire vessel. And particularly if you reconstruct a cross-section of this artery, you can see that basically the entire cross-section of the artery is calcified. And I'll show you some data in a second. This is very predictive of failure for CTO recanalization. Here's another successful case. Once again, a straightforward case with very little calcification, just a bit at the entry here, a straight, non-calcified, straightforward segment. Here's the angiogram before and after recanalization. And as I said, quite a few authors and study groups have addressed this. The prediction of successful recanalization of chronic total occlusions. And predictably, it was calcium, severe calcification that would predict failure, as well as what is called the blunt stump. I'll talk about this in a second. And some authors identified the length of the occlusion and the degree of bending, more than 45 degrees bending. But if you look at all of the publications, we'll not go into detail. Basically, it was calcification or the lack thereof that would predict success, and the presence of significant calcification, mainly not so much the longitudinal extent, but the question whether there's any cross-section that is entirely calcified, as one can easily imagine. This is predictive of failure or of non-success. But then again, this is information that you can only obtain from CT. But then again, the question is, to what extent does it really change your approach? Do you try anyways? Would you not try just because you saw these calcifications? So this has not been transported in the clinical practice. Based on our experience, we do this a lot, and based on the data, if you summarize across all of the many publications, and basically the most important parameters are what I said: the severe calcification, especially the cross-sectional extent of calcification, which is predictive of failure, and the presence of a blunt stump, which means that you don't have a clear entry into this occluded segment. That is problematic. These have most frequently been identified as failure predictors of failure. And this is also something that sort of goes along with our experience. Now, predicting success is one thing, predicting success and failure, but of course it would be much better to know that the use of CT prior to the CTO procedure improves success, whether we can be more successful with this procedure by having CT. And superficially, there seems to be some data that suggests just this, but this is almost an exercise in looking at meta-analysis, because this, for example, is a meta-analysis that says if you take all the published data, there's a odds ratio of 1.9 that recanalization will be more successful if you have a CT prior to the procedure. But then if you go to the details, this meta-analysis consists only of 3 trials. Out of the 3 trials, really only 1 trial was clearly positive. I happen to know this trial very well, which was published in the year 2013, so a long time ago, and only had 50 patients. And there was a success rate of 88% if prior CTA was available, and 64% if CTA was not available. Then if you look at the details of the data, you can see that this was not randomized, but much rather longitudinal. The first patients had been done without CT, 64% success rate, and then the subsequent patients had been done with CT, 88% range. So just the learning curve by itself, the fact that maybe having CT made the investigators try harder, maybe this is already enough explanation for the higher success rate. So a clear example of how meta-analysis can hide information rather than provide enhanced and better information. Really, there is no data out there at the moment that would tell us that using CT prior to CTO recanalization will improve the success rate of this procedure. We do use CT, and we look at the CTs very intensively when we expect problems with our CTO procedures. And the one area where I think it's most useful is the entry. As I said before, whether you look at the CT or the angiogram, lack of a nice entry into the occlusion, a blunt stump, is a problematic situation. And here's an example where at first sight, this shows nicely what CT can do. At first sight, you might think that there is a nice stump. You might think that if you look closely here, there's a little something going down. Also in CT, you might think, there's a stump going into the occlusion. If you don't look carefully, you might, see this here, right there, looks like a stump. And maybe this is an easy case, because if you put your wire in there, then penetrating the occlusion and opening it up should be almost very easy and straightforward. However, as I said, this is an area where you really have to look at the details. And the the dimensions that we're looking at here is something like 0.2, 0.3 millimeters, really, really small structures. So when these CTs are analyzed, you have to be super careful. And this projectional image doesn't really help us, because if you look at the axial image going up and down, you can here see the occluded segment. You can see the pretty much the end of the open segment right there. Something seems to penetrate into the occluded segment. It's this. But then as you look closely, this is a branch, a side branch, a tiny side branch that goes towards the right ventricular outflow tract. So this is not an entry point into the occlusion, but much rather this is a tiny branch going to the right ventricular outflow tract. And this is the degree of detail with which these studies have to be analyzed. I mean, these are structures of far less than 0.5 millimeter that we're trying to see, trying to extrapolate, get information from about how to pass our wire. So this was not a successful entry site into the occlusion. So then finally, the team decided to go for a retrograde approach, go down the diagonal and up the LAD to open up this case. And I'm only showing it to emphasize how, this is the result after the recanalization, how accurately these CT scans should be evaluated, but also what sort of information these CT scans can really provide if you look at them very, very carefully. Extremely meticulous study is required and nothing superficial in these cases. There are a few other aspects that I personally do estimate rather highly by having CTs prior to interventions or prior to making decisions about interventions, especially in the context of CTO. Here, for example, a patient, previous bypass surgery, the typical small coronary arteries that you see in these patients who have had a long history of coronary artery disease. There's an occlusion here, but the vessel, this is the left circumflex overall, seems very small. So the consideration whether reopening this vessel is really a serious one. Should you attempt to reopen this vessel, or is it just very small and really doesn't make any sense? And that's a bit problematic because not always can you estimate based on the angiogram how large the territory will be that fills if this vessel were to be reopened. But in CT, you can see this rather well. You can see the occlusion here, and you can see that a relatively long artery, a relatively large territory is behind this occlusion. And this then leads you to reopening the artery, and you can see what a large artery can be reestablished. This is not routine. This is not something that we need every single time. Certainly not. This is also information that potentially you might obtain by very thoroughly studying magnetic resonance. And usually you also be able to get this information from retrograde filling in the angiogram, but not always. And having the CT to estimate the territory behind an occluded segment can sometimes be useful. I don't want to overemphasize it because it's not something that is routinely required. There's also, if you're talking about CTO, the interventions that are more difficult than the other interventions, the option to fuse CT and invasive angio. And of course, there's often enthusiasm about fusing different imaging modalities. To be honest, in the cath lab, in the coronary situation, fusing CT onto the angiogram, other investigators and we ourselves typically find it distracting more than useful. One aspect that is useful is that it can help you find orthogonal projections, avoid projections where the vessel segment you're working on has a lot of foreshortening. Here marked in red, for example, the segments that would be significantly foreshortened in this projection. So you can try to avoid this. And then very honestly, once again, the experienced investigator typically doesn't need this. You know where there's foreshortening. You can try another projection and you will see it. So that this fusion thing really hasn't caught on. So once again, CT for chronic total occlusions, has it been explored? Yes, quite a bit of research has been performed in that area. Is it a game changer? Rather not. The likelihood that this will significantly improve the outcome after CTO or the results of attempting CTO, the likelihood is low. No large data is available. And again, it's nice to have, but I would not, to be honest, I mean, I need to tell you what the situation, would not consider a game changer. A game changer, it is not. So overall, there are, I would say, limited indications in the context of coronary intervention. If I have a patient who has a CT scan and the patient is in the cath lab and needs an intervention, I will typically look at the CT scan to get as much information as I want. but infrequently does it change my my approach to the procedure. And the invasive angiogram is really very, very good in giving us information. And here you can see once again the degree of accuracy about what is going on in these lesions. Limited indications of context of corneal intervention. You also have to be aware that if you really need to know more, we have unbelievable options in the cath lab. I know there are interventional cardiologists in the call, and the cardiologists in the call, you know this, but also the radiologists probably know that we can do OCT, optical coherence tomography, or intravascular ultrasound during our interventions. And here's the resolution that we can achieve by OCT. The resolution is 0.04 millimeters. So both here, for example, a dissection can be visualized with unbelievable detail. Structures can be measured with extremely high accuracy. Here you can see a stent, which is not completely opposed to the wall, and you can exactly measure the distance, 0.25 millimeters. And this is far beyond anything that CT could ever do. And this is why we have methods that give us perfect spatial resolution and very high accuracy. And having to resort to the ECT or the amount of extra information that we can get off the CT that really changes something. Does it really change something? That's the question. Is relatively low. So limited indications in the context of corneal intervention, but I would immediately say a very important role for non-coronary interventions, which of course have an increasing importance in the cardiac cath lab. Very important role for non-coronary interventions. And the poster child, so to speak, is for non-coronary interventions, of course, is the TAVR procedure. I think you call it TAVR, we call it TAVI, where CT is used. I'm going to talk a little bit about how CT is useful, why CT is so useful in the next few minutes, using the example of TAVR. Now, why is it that CT is so interesting for interventional cardiologists who perform structural interventions? Well, just take a step back and think about what CT is. CTs, modern CT systems acquire approximately 250 or 300 very, very thin slices, continuously stacked slices of the chest, about 300 slices within a few seconds. The temporal resolution, depending on the scanner that you have, there's a large variability, but let's just say is about 100 milliseconds. Temporal resolution, order of magnitude. They are synchronized to the EKG. The images are, we have an 0.5 millimeter in-plane resolution. Here you can see such an image, 100 millisecond temporal resolution, 0.5 millimeter in-plane resolution gives you this fantastic accuracy to visualize the cardiac anatomy in the imaging plane. Mitral valve, aortic valve, right coronary artery, there's some plaque. You can see the pericardium here is a very thin line, the LAD and the vein next to the LAD, circumflex, marginal branch, this is the circumflex. So unbelievable amount of detail. Now the interesting thing is the in-plane resolution is 0.5 millimeters and the slice thickness is also typically approximately 0.5 millimeters. Okay, it might be 0.6 millimeters and the spacing might be 0.4, but we are in the order of magnitude of 0.5 millimeters, which means that the in-plane resolution and the slice thickness are approximately the same, which again means that our volume data set, which is made up of slices which have the same thickness as the in-plane resolution, this volume data set can be reformatted in any orientation that we want, because the spatial resolution is the same in plane and through plane. We call this an isotropic spatial resolution. And this is what makes CT so interesting. We have a volume of the heart, can slice it in any orientation that we want, and always retain full spatial resolution. This is different from echocardiography, where we typically have one slice with very nice resolution, but only one slice. And if you have 3D echo, the resolution is not quite as high. Magnetic resonance, very good in-plane resolution, but the through-plane resolution typically 1.5, 2 or 3 millimeters, not the same and as the in-plane resolution. So the ability to have a data set that is homogeneous and can be manipulated in any way we want and create any slice we want with very high spatial resolution, and in addition, good contrast between the blood lumen and everything else. That's very, very interesting for structural interventions. CT allows imaging of the heart with high and isotropic spatial resolution, and for all practical purposes, it can be considered isotropic and to be about 0.5 millimeters in all directions of space. This is why not only can we generate nice 3D reconstructions, but this is why we can generate oblique slices in the typical cardiac planes or in any other arbitrary plane with very, very high details visible because of the high temporal and spatial resolution. Here you can see another case where you can see two lower parts of the cusps of the normal aortic valve. This is the sinoatrial nodal branch coming from the right coronary artery. You can see the mitral valve and the chordae tendineae. You can see the papillary muscles and the fact that the papillary muscles don't really touch the wall of the left ventricle. So this is the degree of detail that we see in cardiac CT. The left-sided structures are always very good to see because we have homogeneous contrast enhancement in the left atrium and in the left ventricle. Contrast enhancement of the right atrium is problematic because you have the blood, typically you inject into the arm veins, or you have the blood from the superior vena cava coming in with lots of contrast, and the blood from the inferior vena cava coming without contrast, and they mix in the right atrium, and this is why visualizing the right atrium can be more challenging. But for the right ventricle, the left ventricle, and the left atrium, you typically have very, very nice and homogeneous contrast enhancement. So as I said, poster child TAVR, transcatheter aortic valve implantation. And this is, in all the institutions I know now, an intervention that is completely based on planning by CT. And I would like to go through with you because it so nicely illustrates how CT can be useful and what to watch for when we analyze CT for structural heart disease interventions. In addition to the high isotropic spatial resolution, CT with modern system also affords very rapid volume coverage. So with one reasonable injection of contrast agent, we can visualize the entire central body. And it's also sensitive to calcium, which both are very advantageous when thinking about TAVR. So we have rapid volume coverage. We can cover the heart and we can cover the iliac arteries. And because of the high and isotropic spatial resolution, the iliac arteries can be nicely reconstructed. We can reconstruct planes that correspond exactly to the plane of the aortic valve and other planes that show the aortic valve itself. And here you can see the calcification. So it shows how you can analyze the relationship of calcified towards non-calcified structures. And all of this is part of why CT is so useful for the TAVR procedure planning and the identification of patients who can undergo this procedure without particular risk and with promises of good outcome. So there are four in most institutions, very well-defined questions that are asked from CT prior to the TAVR procedure or while working up patients to identify whether they are candidates for the TAVR procedure. Vascular access, the problem of coronary obstruction, dimensions of the aortic annulus and aortic root for sizing of the prosthesis, and finally, the optimal fluoroscopic angulation to perform the procedure with an orthogonal view onto the aortic annulus. So these four questions: vascular access, coronary obstruction, size of the aortic root, prosthesis sizing, and optimal projection, those are the ones which are very straightforward and very routinely answered by cardiac CT. Vascular access is almost a non-brainer. You can visualize the iliac arteries very accurately. There's a number of information that is extracted. Some of it is very quantitative and can be measured. Others is much more subjective, and this might make things a little bit more difficult. So measuring the lumen diameter is extremely quantitative. You simply measure it. You take care that you have a plane that is orthogonal to the vessel, and then you can visualize the contrast enhanced lumen and the non-contrast enhanced components. And this is obviously a very, very small vessel with only about 2.5 millimeters diameter. So either you have to dilate this lesion or you need to select a different approach. So measuring the lumen diameter is really very straightforward and very quantitative. And it has been shown that the relationship of the sheath that you plan to use towards the minimum diameter in the iliac arteries that you measure is the best predictor of complications such as unplanned surgery, minor bleeding, major bleeding, and other major complications. So simply the vessel should not be smaller than the sheath. Somewhat less quantitative, but still relatively accessible, is the presence of circular calcification when the vessel is borderline. When you have a very large vessel, here distance, you can easily tell, is German for distance. When you have a very large vessel, then even a circular calcification is not a problem, because you can easily pass the sheath, and the valve typically, when it's put into the sheath, expands the sheath a little bit. If there's enough room, it's not a problem. But in vessels of borderline diameter, circular calcification can be very problematic, because you can basically get stuck in the middle of the procedure, and the prosthesis will not, trying to put it into the iliac artery, will not move forward and not move backwards. And that's the case when you have borderline diameters and circular or almost circular calcification. And this is a little bit less quantitative, and this is why you might have to be discussing things when you see this, and might want to actually get the interventional cardiologist, if the interventional cardiologist is not reading the images themselves, routinely to look at this together, because there are borderline cases. Then something that is very subjective is the degree of tortuosity. Tortuosity by itself is not a problem. Tortuosity, look at this case with severely tortuous iliac arteries, but they're not calcified. And if a severely tortuous vessel is not calcified, every interventional cardiologist has tricks to easily straighten those out. And then with a wire and a catheter, and then once you have a stiff wire in, you can easily pass your sheath and your prosthesis. So as long as tortuosity is not calcified, it's not a problem at all. Of course, you should know about it. It might be a problem for the closure systems, depending on what closure system you use for the arteries. But in principle, for putting up a sheath with a straight wire, if it's not calcified, you will be able to straighten it. It's different when you have calcified tortuosity. Significantly calcified, significant bends, more than 90 degrees, significantly calcified, can be problematic. Even though the vessel lumen is okay, you might not be able to get the sheath up. And either specific pre-treatment or choosing an alternative approach, which might simply mean going to the other side, might be necessary. But calcified tortuosity is problematic. Once again, borderline, hard to quantify, might need discussion if the situation is seen in reading the scan. That's vascular access. Closer to the actual matter is the situation with the coronary ostia. When the aortic root is a narrow space and you have the aortic annulus where the prosthesis will be placed, the leaflets of the native valve will be displaced. The prosthesis itself also takes up some space, and you can imagine that if the coronary ostia were too close to the ostium, to the annulus, and if the native cusps, when flipped upwards, would cover the ostium, it would potentially be a problem. Here is such a case where the left main coronary artery is extremely close to the aortic annulus. The aortic annulus cusp here is severely calcified, and flipping this upwards would likely mean that this is simply pressed into the ostium of the left main coronary artery, and the left main coronary artery is occluded. This happens. These things happen. And sometimes they can be solved interventionally by putting in a stent, and sometimes they can also cause significant problems. Here's such a case. This is what it looks like in the cath lab. The prosthesis is in, but the true lumen of this left main now is almost as thin as a thread now, because all of this here is the calcified, large calcified nodule, which has been pushed into the ostium of the left main coronary artery. The patient was not doing well at all. And here's the CT scan of this patient. At first sight, you think, there's a lot of space here between the aortic annulus and the ostium of the left main coronary artery. But then you understand, as you look at the cusp, this cusp is very long, and there's almost a soccer ball full of, this is Germany, we say soccer ball, a soccer ball full of calcification sitting on this cusp. And then you can measure this. I mean, the distance here is 14 millimeter. The length of this cusp is 16 millimeters. You consider all of this calcified plaque, and you can imagine that problems would occur. So once again, unfortunately, this is not just one measurement, like lumen diameter in vascular access. It's a little more subjective and multifactorial, and you have to take a number of things into account and measure every annulus situation separately and consider everything that you know to estimate whether there will be a degree of endangerment that the left ostium might occlude. There's data out there, and there's these numbers. The numbers have been out there for a while that say if the ostium is more than 10 millimeters away, no problem, you can do the procedure. But then if you look at the published data that looked at patients who experienced coronary obstruction and patients who did not experience coronary obstruction, you can see, yes, of course, in general, those without obstruction have a much longer, they call it height, or longer distance from the annulus to the left main than those who experienced obstruction, where the average distance was lower. But this threshold of 10 millimeter can't be held up, because even cases as distant as 16 millimeters from the aortic annulus still experienced obstruction in some cases, as you can see here, where the distance is 14 millimeters. And as I said, it's not just the distance, it's the relationship between the distance of the left main ostium to the aortic annulus, but also the size and the degree of the calcification of the cusp below the left main ostium. So when you read these scans, you need to look at the cusp length and the amount of calcium on the cusp, the distance from the hinge of this cusp in the annulus towards the left main ostium, and also the depth of the sinus plays an important role. So all of these things have to be considered, and there's no formula, no score, no single measurement that will help you. You have to simply put this all together, and in questionable cases, start a discussion with some colleagues or with the interventional cardiologists, and also think that's what we do. Well, this is looking dangerous. How urgently do we want to avoid surgery in this patient? If this patient is a good surgical candidate and I fear that something might happen, maybe then it's better to go to surgery. Particularly important is this assessment, whether there's obstruction risk for the left main and the right corneosteum in patients who have a valve-in-valve procedure scheduled. A TAVI inside a bioprosthetic valve sounds like the easiest thing to do because there's a good landing zone, but these bioprosthetic valves are often sutured very close to the left main ostium. And then if you flip the cusp upwards, the native cusp of the old bioprosthetic valve, this cusp might easily cover the left main ostium if the bioprosthesis is sutured too close to the left main ostium. So this needs to be very carefully looked at individually in every single case. And the rate of obstruction or the rate of danger of obstruction in valve procedures is higher than in native arteries. The third parameter is obviously the dimension of the annulus, because this determines sizing. Which size prosthesis to choose? Is there a good prosthesis for this patient? And if so, which size is the best size? And there's two methods that are used. Some products are sized based on the area that is measured. Others are sized based on the circumference. Sometimes both is taken into account. But anyways, the idea is to very accurately visualize the aortic annulus in CT by choosing a suitable plane, and then either measuring the area or the circumference or both, and determine sizing of the valve. I have to say that doing CT and interventions really has opened my eyes here, because the typical valve size are 23 millimeters, 26 millimeters, 29 millimeters. And as a cardiologist, honestly, if you don't get in touch with this like the surgeons do, the perception might be, come on, 23 millimeter valve or 26 millimeter valve, the difference is 3 ridiculous millimeter. The difference is 13%. How can this make a reasonable difference? I mean, 23 or 26 is not such a big difference. And the same thing if you think 26 versus 29, this is not a big difference. I mean, this is just close to 10% difference in the diameter. This cannot be that important. 3 millimeters cannot be that important. And then if you look at these prostheses, because we don't typically see them, we don't typically see aortic valve. If you look at the prosthesis, a 23, a 26, and a 29 millimeter valve, you can estimate how massively different they are as far as size is concerned. Because 23, 26, 29 is only the radius. The area goes by the square of the radius, and the resistance goes with the fourth potence of the radius. So between the 23 millimeter valve and the 26 millimeter valve, you have a 30% 30% difference in area and a 60% difference in resistance to blood flow. So we need to be aware that for the patient, of course, it's advantageous to get a larger valve because the resistance will be substantially lower, but it's also massively dangerous to implant a valve that is too large because you might rupture the annulus, and massively dangerous to implant a valve that is too small because you might end up with significant paravalvular leak. So there is not just a marginal difference between 23, 26, and 29 millimeter valves. The difference is substantial if you see the actual valves, even though the diameter only has about 10 to 13% difference. And CT can size extremely accurately, and that's a massive advantage. CT also allows to choose larger valves. Here's one comparison between 3D, TEE, and CT. And you can see, for example, that the 29 millimeter valve was chosen in 18% based on TEE, but in 44% based on CT. So we can give our patients larger valves by using CT for sizing. The fourth component is the angle. When doing the procedure, it is desirable or even necessary to have a fluoroscopic view that shows the aortic annulus exactly orthogonally. And the favorite view is the one where you have the left coronary cusp here, the non-coronary cusp here, and the right coronary cusp in the middle between them. And this view can easily be predicted based on the CT scan. You can simply measure the angle in which you will obtain an orthogonal view onto the onto the aortic annulus, can easily be measured by CT. And this has been evaluated, for example, in a series of 100 patients. And you can see that you can reduce the number of angiograms that are necessary in the cath lab. You can reduce the amount of contrast necessary in the cath lab by identifying good projection from the beginning and putting the C-arm in the respective position. The use of CT in the context of TAVI has become standard. So the data is old that looked at the usefulness of CT. Here's one non-randomized trial. Always careful. I showed you a previous example where you can see that in 260 patients, the incidence of more than mild regurgitation was significantly lower. If CT was used for planning, 5.3%, as compared to the control group without CT, 13%. There was also lower, but not significantly lower, in-hospital mortality. But these are old data from 2013. There's one randomized trial even. I mean, these days, you wouldn't be able to do this anymore, randomized TAVR with and without CT. And you can see here that without CT, 60% were event-free after 365 days. And with using CT, 92% were event-free. Very small series, very optimistic estimate of the event-free group using CT, but randomized trial, very strong, and very strong design, even though small, an advantage of CT. So once again, vascular access, coronary ostia, annulus dimensions, and sizing of the prosthesis and fluoroscopic angulation are what we routinely do. There are a number of other things that can potentially be looked at. I mean, we still need to learn. Does the length of the membranous septum, as some investigators have suggested, predict the need for pacing, predict the occurrence of AV block? Does the degree of calcification below the non-coronary cusp, as some investigators have suggested, really predict the incidence of the catastrophic complication of annulus rupture? Can CT help identify, out of those patients who have a bicuspid valve, those in whom the procedure can safely be done, the true bicuspid ones without a RAFI, or at least the RAFI without a lot of calcium maybe? So these are questions which are interesting, and we are starting to see some data on, but they will be more difficult to questions, and we do not have a definitive answer yet. And just recently, 2 or 3 weeks ago, there was a nice publication looking at bicuspid valves, once again, retrospectively, and the complication rate in bicuspid valves after TAVI, depending on the pattern of bicuspidity and calcification. And you can see that the mortality was significantly higher in those patients who had severe calcium and a calcified RAFI, such as this patient would be considered. Bicuspid valve, severely calcified RAFI, and you can imagine this is this calcified RAFI, and if you push this outwards, it might rupture the aortic wall, and this is potentially the mechanism why these severely calcified valves with the calcified raphe are dangerous. Lower mortality if there's just a tiny bit of calcium or almost no calcification, and particularly no calcification of the raphe. Then we have very low mortality after TAVR in bicuspid valves. This was a study of more than 1,000 patients. It's a retrospective analysis. We're always careful, but it shows that CT has the potential to help us identify those patients with bicuspid valves who can safely undergo the procedure. So in addition to the 4 standard parameters to look at, there's a number of additional parameters where CT could be useful. This is important because TAVR is changing. TAVR, transcatheter aortic valve replacement, used to be a procedure just a few years ago for patients who had no other option, who were very high risk, prohibitive surgical risk, very high risk, patients often old with a limited lifespan. And in this situation, a certain risk was acceptable, and the short-term outcome of TAVR was important. 88-year-old patients with shortness of breath and a very high surgical risk would be a TAVR candidate. And a certain risk of the TAVR procedure would be acceptable because it's still better than the alternative of doing nothing or performing very high-risk surgery. And it's also with the older patients short-term outcome that is important. But this has changed. We're continuously moving TAVR towards a lower risk population, challenging surgery in patients who would also be good candidates for surgery. Maybe a 67-year-old or a 75-year-old is asking for TAVR. Patients with low surgical risk, patients with a long lifespan. And if you want to do TAVR in this population, we have to make sure that there's absolutely minimal procedural risk because surgery is relatively safe in these young patients. And they also have to make sure if you perform TAVR in this low-risk young group, that the long-term outcome is optimal, not just the short-term outcome. And here's the role for CT that will help us and will have to help us identify those patients in whom we can predict a minimal procedural risk and in whom we can reasonably expect a good long-term outcome. And this is going to be a very, very important role for CT to identify those patients where TAVR is really, really low risk, so it can be and should be used even though surgery is also possible. A little bit more broadly, and I'm almost done, thinking about CT for structural interventions, not just the transcatheter aortic valve implantation. The 2 main parameters that are useful and that are extremely useful is target anatomy on one hand and projection, the optimal projection in the cath lab on the other hand. Highly useful and often underutilized. Ductus, here's an open PDA between the pulmonary artery and the aorta. We call it ductus botalli. I think you call it PDA in your country. And this was supposed to be occluded. CT can show you exactly the optimal viewing angle of this connection. So once you have this angle, you can easily put a wire through, insert the device, and occlude the PDA and CT to predict the optimal orientation here, where you can really see this well, is extremely useful. Another example is paravalvular leak closure. This is a patient who has a bioprosthesis of the aortic valve. You can see the frame, you can see the cusps of this bioprosthesis, and you can see the leak next to the bioprosthesis. And the closure procedures are facilitated extremely by knowing exactly where the leak is and what is the best orthogonal projection, what is the best C-arm orientation to see orthogonally onto this leak. And once you know this, you know exactly where to look, and you can put down your wire, insert your sheath, sounds a bit easier than it is in reality, and insert a closure device. But the projection obtained from CT is highly useful. This is a perforated sinus valsalva aneurysm. You can see the aortic root here. You can see the perforation of the sinus valsalva aneurysm into the right ventricular outflow tract. Once again, the orientation can be taken from the CT, which helps us localize this very accurately on the invasive angiogram without spending too much contrast. And then a closure device can be inserted and the leak can be closed. It's really the orientation, which is highly useful. And we use it for all our structural interventions. Using the CT to determine the optimal orientation is highly useful. New interventions in the heart are constantly developed. They come and some go, and of the new interventions, which some are very elaborate, CT is increasingly used for accurate sizing, selecting of patients, and visualization of the target area. This is one patient who received a parachute device, a patient with heart failure, to make the left ventricular cavity smaller. No longer use this device, but you can see how CT can visualize this extremely nicely. This is not a simulation. This is the actual device inside the patient's heart. Tricuspid valve band repair, also heavily reliant on CT to identify the best candidates. And also, this is the case of tricuspid regurgitation, also to measure and determine the tools and the eligibility of the patient for the procedure. So in summary, thinking about computer tomography for cardiac interventions, two aspects. One is coronary intervention. And to be honest, even though CT of the coronary arteries is extremely useful for diagnostic purposes, and you wouldn't completely ignore the information that you have from CT when you go to intervention, CT is so far not been proven substantially helpful in order to perform coronary interventions. You can see the difference in image quality and the high accuracy that we can obtain with the invasive angiogram. And there's no recommendation at this point in time for specific cases that you have to perform a CT before the intervention in order to make the intervention good. On the other hand, for structural interventions, and TAVR is the prime example here, visualization of target anatomy, optimal projection, and the best access pathway has been shown to optimize outcome, avoid complications, and reduce risk. So CT is absolutely essential and will become more essential for current and future non-coronary cardiac interventions. And with that, thank you very much for your attention. As far as I understand, now we have a bit of time for questions.
Thank you very much for the lecture. Asim Latif will be joining us for the moderation. I think he will start with a question.
Yeah. Stephan, thank you so much. That was an incredible overview of CT and the role in really guiding interventions, whether it's coronary or structural. I wanted to start maybe with coronary first before we move on to structural.
Oh, sure, as you wish.
And just maybe ask a question there. So the one area, we've been pushing a little bit of using CT up front are patients with suspected SCAD and spontaneous coronary artery dissections, and trying to avoid putting catheters into these patients. Have you had any experience with in using CT as the primary diagnostic strategy for these kind of patients?
Of course, we have experience with a few cases, and I can tell you that sometimes these SCAD are very hard to see. And you will need absolutely optimal image quality, particularly since some of them are located rather distally. And the fact that it might be just a hematoma, an intramural hematoma, and unless image quality is optimal and the SCAD is in a reasonably large vessel segment, I fear that some of them might be missed. But this is just my personal opinion, and I don't have any data on it. So you're completely right, because in the SCAD patients, of course, we worry that by inserting a catheter into the coronary artery, and I know some terrible cases, we can make it worse. But I'm a little bit worried that to use CT. I think what you can do is use CT. If you see it very clearly, you have your diagnosis. But if you don't see it, you should not completely rule out the possibility that still this might be a SCAD patient, that this is either very far distal or that maybe you just miss it because it's not clear to see.
Yeah, absolutely. Thank you. If I may, Leandro, I had another question as well, please. So, I'm a strong believer like you in using CT scan for structural heart interventions. And TAVR really has been the sort of the brainchild of teaching us how to use CT on a regular basis.
Absolutely.
I mean, personally,
it opened the door into the cath labs for us. Yeah.
Absolutely. Yeah. Personally, I feel, occasionally there are these patients with severe kidney disease where I have to do a TAVR without a CT, and I feel very uncomfortable, I have to admit.
Well, actually, even if we have the most severe kidney disease, we will always do CT. We do CT with about 25 milliliters of contrast in these patients, but we get the iliacs, we get the aortic root, and we use this contrast because we think that then later we'll save it in the procedure. But
So
sorry, I was interrupting you.
No, but that's part of that's one. It's a two-part question. The one part was how, when you're trying to minimize contrast in patients with chronic kidney disease, what was the, how do you do that? Maybe even if you could, on a more
scan and a very
technical.
low flow rate.
Sorry, say that again.
We use the so-called flash scan to visualize both the heart and the iliacs at the same time. And we reduce the flow rate to 3 milliliters per second of contrast when we inject, and that's how we can get these very low rates.
Okay. And then the second
question. But
question.
it's not an easy situation. I completely agree with you. It's not an easy, straightforward situation.
And then the second part was, how often can you avoid doing the coronary angiogram in a pre-TAVR patient using the CAT scan to exclude coronary disease?
You're asking all the good questions, I have to say. Excellent question. And my estimate that we can avoid the angiogram in about 40% of cases, I would say.
Okay.
Because many of them, we don't routinely heart rate lower these patients. We just scan them at the native heart rates. Many of them are severely calcified. Some of them are a little bit on the heavy side also. And we don't give nitrates because of the autograft stenosis. So image quality for the coronaries in these patients is lower than the image quality in patients who have a dedicated coronary CT scan. And I would think that in about 40% of cases, we can say there is no significant stenosis. I mean, if you don't see the distal segments, we don't care. We just want to see the proximal and the mid segments. And if it's a very small right coronary artery, we also don't care. You have to, just take the overall picture into account.
Yeah, absolutely. Leandro, maybe you want to take some of the questions from the chat?
Sure. I'll start with one question. I think that was an amazing lecture. And my question is, on the patients with CTO, are you using the late iodine enhancement, or do you think that could add? And how is the quality when compared to MRI right now?
Since I know that you appreciate an honest answer, I'll give you one. I mean, it's very difficult to see, right? And typically, before we do the CT scan, we already have our MR because we have a decision that we want to or do not want to do the CTO. The late enhancement in CT is something that you can do. Maybe it's going to be a little bit better with dual energy and all of these things, but the image quality doesn't blow you away typically. It's difficult.
Okay, great, thank you. I think we can start with the questions from the audience. There's a question from Aisha Kader that says, could you comment on the use of CT in visualizing those with CABG, while grafts are generally well visualized with CT? The native coronaries in such cases are usually very calcified. How does that work?
Well, you tell me, nobody knows. That would be an excellent area of research, but it's the observation that in patients with bypass, and probably because the flow is different, the native arteries often calcify heavily. Of course, these are patients with severe coronary artery disease to begin with, but then obviously over the course of time, the acceleration of calcification is particularly high. And the experience is, as you very correctly say, that we can typically read the bypass grafts very well, but unless image quality is optimal, the native arteries can be difficult. So we are relatively reluctant to scan the bypass patient with chest pain by CT. We rather do an MR, stress MR, because it often then gives you also the information on viability that you might want in all of these things.
Do you think stress perfusion with CT could help in these cases?
It could probably help if it worked well. So far, we have not found a protocol that blows us away, and but I'm sure this will come, but not for now. I mean, stress MR is just a nice test.
Okay, great. That's very good. So from Ethan Goldberg, we have a question. Wonderful talk. Do you see a role for fusion of CT with TE for structural interventions?
It's certainly a creative idea. Usually we want to fuse to have more information during the intervention. So maybe it can be done, but I'll tell you a secret. I'm not a big fan of image fusion to begin with. Usually one modality is just annoying and obstructs your clear view into the other modality. So there's not a lot of fusion going on in my department, even though all the companies want to give us their equipment and have us say that this is fantastic. The fusion happens here, right? Right, you know that the vessel is calcified after the second diagonal branch. You see the second diagonal branch, you know where the calcification is. So the fusion, I'm not a big fan, but the idea of fusing CT with CEE is certainly a creative one.
Yeah. We've tried Leandro with TAVR in the past. I mean, there've been so many companies that have come up with different software for TAVR, where you overlay from the TAVR the aortic valve and the coronaries, and all
Yeah,
I've found it's been distractful and
yeah.
distracts you from the
Distractful
procedure.
is the better word. Yeah, it's distracting. Yeah.
Um, there may be a role, I think, with fusion and TE, maybe in tricuspid, maybe in mitral. There may be some role for having the
So
TE.
flexible, right? And then you have a
Yeah.
different filling status of the right ventricle, all the dimensions change. The only area where I see fusion a little bit maybe is the puncture, right? If you have large bore axis and things are not moving so much down there and you want to know where can you go in without hurting anything, that's a theoretical construct where I could imagine fusing the fluoroscopic view during the puncture with ultrasound or with the CT information that you have. But this is just a theoretical construct, nothing specific, because this is not moving so much. And I mean, in the heart with respiration and different fluid status, as I said before, changes in heart rate. I mean, the heart is a wonderful organ, right? Because it changes all the time. But this is also what makes fusion relatively difficult.
Yeah.
We have another question from Rupesh Singhal. It says, great talk. What is the role of CT in determining percutaneous mitral valve repair technique and devices, especially with reference to annuloplasty devices?
Yeah. Well, the mitral clip, you don't really need CT. For the annulus repair devices, the companies and the developers will usually want CT for a number of reasons, which is the exact geometric configuration. So easy to determine by CT, much easier than echo or even 3D echo. And also the relationship of the circumflex artery or the distal right coronary artery to the mitral annulus, or if you think about the tricuspid valve, to the tricuspid ring, because you might hurt these arteries. And so CT is indispensable in these procedures. Once again, a contrast problem. Many of these patients already have a tiny bit of renal failure, particularly, of course, the tricuspid, severe tricuspid regurgitation patients, but you need this information, so you need to spend the contrast agent. And if the patient is so sick that he or she cannot have any contrast, then you have to reconsider what you can do for them.
Stephan, maybe in relation to that, I when I lived in Europe and Milan, I did a lot of cardioband, and CT was really essential to us understanding where to put our anchors, what size band, and so on. The one area that we thought we started dabbling into trying to understand, using Hounsfield units and so on, is tissue quality. Right? Because if you have poor tissue quality, maybe those anchors are not going to stay there. Has there been any more advancement in trying to really look at tissue quality?
Not that I know of, no. No, a soft tissue differentiation is difficult by CT. You can see calcium very nicely, but trying to differentiate soft tissue is a problem that CT has.
And do you think there's going to be any advancements in really evaluating function as well? I mean, we're working a lot on the tricuspid valve and tricuspid valve replacements. And one of the biggest challenges we have right now is trying to evaluate RV function and how good the RV function is. Because some of the echo parameters help, but they don't always help. And we're now looking at what other modalities we can combine along with echo to try and understand RV function.
CT is cool. You can do, there's software that gives you volumetric assessment of the right ventricle and systole, diastole. Very hard to quantify, of course, flow can't, pressure can't, but volume changes you can easily see by CT.
Okay.
I think another question is, what's the status of CT imaging stents? When should we use CT for patients with stents, and what advances are being done on that?
Your group is asking the good questions. I'm not a fan. Probably 3 millimeters upwards, if image quality is good, can be imaged rather reliably. Below 3, I would keep my hands off. It's too likely that the patients will have terrible image quality. And also, if it's a 3.5 millimeter stent and the patient weighs 300 pounds, don't even think about it. Image quality has to be perfect, and then you can do it. Luckily, the stent problem has been significantly reduced because the stents have become so good. So in-stent stenosis, which we used to see all the time just 8 years ago or so, or 10 years ago, is very infrequently encountered, at least here in Europe. I would assume that you used similar stent models in the US. In-stent restenosis has become something routine, has now become something very infrequent. At least that is my observation.
Leandro, there's an interesting study happening in Europe right now, a randomized study using CT for surveillance after left main stenting, for example. That kind of makes a lot of sense to me, and I'm looking forward to see what that randomized study is going to show, because it's also an area that probably you can visualize better, and where maybe a 50% restenosis that may not be symptomatic, or you may have a negative stress test, you'd actually want to diagnose it early on rather than waiting for the patient to get to a more severe restenosis.
Yeah, probably true, but we need to wait for these trials. I mean, there's lots of trials. I didn't talk about everything that has ever been done. There's also trials that show you that you can plan bypass surgery relatively reasonable based on the CT scan and things like this. But we'll have to see how this all plays out in clinical practice.
Okay, thank you very much. I think with that last question, thank you, Asim, for joining us. Thank you, Dr. Achenbach, for joining us. And that
was, it was a pleasure.
Thanks, Stephan. Good seeing you. Take care.
Good to see you. Good success with your work. Thanks for having me.
Thank you. Thank you. Bye-bye.
Bye.